Welcome to Home Health 360, a podcast presented by AlayaCare. I'm your host, Jeff Howell, and this is the show about learning from the best in home health care from around the globe. Hi, everyone, and welcome to another episode of Home Health 360, where we chat with home health leaders from across the globe. Today, we have two distinguished guests. Richard Keller is a senior P&L leader with 20 plus years of experience in healthcare operations, policy, and analytics. He is a passionate person about improving the value in the healthcare delivery system by reducing total cost of care trends and improving quality. With a primary focus on government programs such as Medicare, Medicare Advantage, Medicaid, long-term services and supports, and dual eligible integration, Richard has driven change throughout his career as president of one of the nation's largest home care companies, All Metro in New York, before an exit of $575 million to Motive Care earlier this year. Richard, welcome to the show.
Thank you.
And Jennifer Maxwell is the co-founder and co-CEO of Maxwell Healthcare Associates, a national leader in the operational and technology optimization consulting space, focused on collaborative use of people, process, and technology for the future of healthcare in the home. Before dedicating herself full-time to MHA, Jennifer held positions as CEO and executive director of the Minnesota Home Care Association and as an executive account manager at one of the top home health and consulting firms. Jennifer is also a strategic advisor at Metalogix, a data science company focused exclusively on home health and hospice. The company was founded in 2011 with a desire to help home health agencies identify patients on census at risk for unplanned hospitalization, and now monitors 30% of all home health patients in the United States. Jennifer, welcome to the show today.
Thank you. Happy to be here.
So let's start with you, Jennifer. That was certainly a mouthful for both of your track records, and I know that you're working on some really cool things in the analytics space. Why don't you give us a little bit more color on your background and how you've arrived to where you are today?
Sure. Well, I come by way of my original background is I'm a counselor by trade. So I started in the acute hospital setting, mental health, did inpatient, outpatient day treatment for the mentally ill population for a number of years, transitioned into county government. So worked for a Department of Human Services in Colorado for just over 11 years. There I was an adult services division head running the 1115 Medicaid community-based, home and community-based waivers, as well as the Area Agency on Aging, Adult Protection, 211, and then created a statewide program that is run in Colorado today called Home Connections, which is the bridge gap between community services and potential waiver program services. From there, transitioned back to Minnesota, as you'd said, and I'm originally from the north anyway, so I thought, well, might as well come back that way. And did the executive director and CEO of the Minnesota Home Care Association for 3 years, 250 home health, hospice, palliative care, and private duty agencies across a 4-state region. We did a lot of state, local, as well as federal lobbying for regulatory burdens and access to better care, better rates, those types of things, and as well as a continuing advocacy and education for our constituents. Transitioned over, did my little stint in the for-profit world with the consulting firm. At that time, my husband today and my business partner, Tom Maxwell, and I both decided we were going to transition careers. I thought I was going to go become a yoga instructor, and he thought he would golf all day. Well, that lasted both of us about 70 days, and we had a calling to come back to the industry. And Tom and I had numerous mutual colleagues, friends, and that were struggling with their agencies and asked us for help. And as it related to the people process and the technology, with Tom being chief strategy officer for Home Care Home Base for a number of years, obviously we had some insight into technology. So we started off a lot with that optimization component. We've now stretched. We thought it would be a lifestyle business, 5 or 6 consultants. we are now 117 consultants strong across the nation and still continuing to grow. We have multiple service lines that range from implementation to project management to augmentation to M&A to rev cycle. To help desk, you name it, we do the full gamut. We also work with vendor partners in the space. Hence, we had the idea, it was just over 2 years ago for Muse, and Muse became a passion of Tom and I, and we had another co-founder with us, Brian Mosier. He was the data science behind our crazy thought process, but our thoughts were, how can we help people that are on hospice not die alone or without care in those last days? And so that's where our world of predictive analytics started just over 2 years ago. And we built the Muse product. And to date, the model runs and through hospice entities and through their EMR, we pull the data and we're able to risk stratify patients and be able to put them on a criticality scale of when there's risk for passing away. Our model to date runs about a 94% accuracy rate of knowing when a patient's going to die within 7 to 10 days. Okay. And so it's pretty amazing technology that it's neural net learning along with specific data points. It reads words. I like to affectionately call it Einstein. Brian would probably tell you it's a bunch of other very scientific words that I don't know. I just know the end result, and I know how to passionately teach that to providers in the space. In the meantime, we just recently, we had always been partners with another firm, Metalogics, which it has the same exact product set on the home health side. And so we were able to transition that. We merged the two companies together in May, and now we have that technology using the AI, the neural net, and data science to be able to predict the full continuum of care on the post-acute care side.
And so what are you predicting in home health then? Mostly rehospitalizations?
So our care model, what that does for us is it takes a home health patient along the lines of what we do with the Muse data, but it will, at a start of care or within an episode, every time a nurse goes out to visit, it will risk stratify that patient and determine visit utilization. How many visits does this patient need and at what time, so that they're getting the right care at the right time? Traditionally, you'll see a lot of 2-week 9, 3-week 9 home health visits on the nursing side. And really what that has done, we've seen CMS react to that, whether it's through on the therapy side. Now we've got PDGM. And so we see this pendulum shifting in reactory models that now with our data science over the next 1 to 2 years, we're hopeful to be able to show predictability and show better patterns for home health agencies in providing the right care at the right time across the full continuum.
So that's very exciting, especially since we're moving into a value-based pay world.
Exactly.
Yeah. Well, that's incredible. And question about Maxwell Associates. I didn't know you guys were at 117 consultants. Are you guys the biggest player in the space?
I would say that, yeah, I think we are. Okay. We run a very unique model of how we do things, but I would say that, we still have Symmetry out there, and you've got the Fozzie group and those, the BKDs and the McBees. Mm-hmm. But again, they are very, with the exception of Symmetry, the others in the space are attached to an EMR, as we are not. And so we're EMR agnostic. So our consultants are extremely versed in the space. They are spun up on all of the potential technology vendor partners that we have that can help optimize our agencies that we work with. And so it really does, it's a win-win on both sides. And we really like our approach. We use a team approach to working with our organizations and more of a partnership. And I think that's really what's Maxwell's been in place since 2016. And obviously we all had the pandemic, but regardless of that, I mean, we've just bounced back even faster as these agencies are now seeing the effects of PDGM and how do they change, whether it's revenue cycle, whether it's their intake process, whether it's their eligibilities. I mean, we're going in and we're really peeling back all those layers. And then teaching them, optimizing the technology, but then teaching them the why behind it. And we're really seeing some positive adoption results for these organizations and really kind of getting themselves right-sided as we see more change coming at us, because we know
Right.
we live in the forever change model.
Yeah.
So, yeah.
Yeah. Even if nothing changed, it's still complicated to start with, and then it's always changing.
Yes. Forever.
Yeah. Well, that keeps us all busy anyways.
That it does.
Rich, over to you. So at 575 million, I know you had a couple of previous exits, and it must be exciting to be part of such a large transaction. And to my knowledge, I think it might be the biggest deal we've seen this year, or certainly in the top five. Bring us through a little history lesson of yourself.
Sure. I mean, so yeah, home care was I was sort of late to the game in home care. I start off, and it's funny in sort of thinking through this this discussion. When I think back to even grad school days, I was always passionate about what we now call value-based care. We didn't call it value-based care back then. I mean, it was really risk contracting or outcomes management. I mean, even so, I mean, I remember studying what Pennsylvania was doing with cardiac surgery and issuing results, and how the different surgeons did on the results. And back in the 90s, that was groundbreaking. Like nobody could believe we're actually going to share performance metrics on how actually are people performing. Went into spent a number of years in managed care and IPA management. Starting to get into risk contracting again before we called it value-based contracting. I was with GHI and also spent a number of years with WellCare. Managing a few regions for them in New York, and then also New Jersey and Connecticut. Transitioned out of there over to a small analytic firm, Treo Solutions, where we were doing We were basically working with managed care plans and Medicaid programs on payment transformation models, right? So simple things like thinking about how do you put in place APR DRG systems and EAPG for outpatient payment for outpatient payment structures to really it's effectively putting in payment models that are rewarding the outcomes that you're looking for. And then we got involved in total cost of care contracting and using risk tools like 3M CRG Grouper to help evaluate what's the total cost of care for populations and identify those individuals with the multiple chronic illnesses that cost the most money, and help pinpoint where the opportunity was for not just risk contracting but also care management programs. Did that for was with them for about 6 years. Treo sold to 3M Health Information Systems, and spent a little time with 3M, and then an opportunity came up in the home care space. I got to know introduced to the folks at Nordic, who owned All Metro at the time. All Metro was was at that time in 3 states: New York, New Jersey, and Florida, and really went in there with the objective of how do we take these concepts that we were working with at 3M and really put it to practice, right? Sort of put my money where my mouth is, so to speak. With the basic premise being, and we've got these caregivers, in people's homes for multiple hours a day, sometimes 24 hours a day, and how do you use that, right? How do you pragmatically speaking, they know what's going on. They're with the clients as much as they are. Oftentimes they know more about what's going on with a client than the family member does. And when we think about value-based care and helping the system practice at the top of their license, well, here you've got caregivers who are making obviously minimum wage or slightly above minimum wage, who are a cost already in the system, right? They're already there. They're already paid to be there. How do we use that? How do we use that to drive value? So that was coming at it from the analytic mindset of a guy who's looking at a bunch of, who's consulting people and talking about the wonders of value-based care, and this is all we have to do. So I said, let me go try it out in the real world as a provider. We made some great progress. We did some really interesting stuff at Simplora on that front. But look, you quickly learn the reality between how things look on paper and then doing it. And so So it was a great lesson. I think you can't, you really can't, you can't express enough how powerful it is to actually get behind the operations to try and figure that out. So I spent 6 years with what we rebranded All Metro to some, after through a number of acquisitions. I mean, currently, and you all can read, and Motive Care has made acquisitions since Simplora, with Care Finders getting further into Pennsylvania and New Jersey. But we rebranded All Metro to call it Simplora Health Group, grew that to 7 states. I transitioned into a role to run the legacy All Metro brand, which again was New York, New Jersey, and Florida, and did that for 3 years.
Mm-hmm. Strictly personal care?
Strictly personal care.
Yeah.
So, All Metro was just personal care. We did some private duty nursing in the Florida market, pediatric private duty nursing, but I would say almost exclusively personal care, and I would say 90+% Medicaid, either through various waivers or, including managed care. A lot, and we had quite a bit of managed care. After Motive Care purchased Simplora and that deal closed back in November of last year. I was there for about 6 months, and then I recently left to look to build, and which we'll get into, but really looking to part. And I've partnered since with Lorient Capital, a private equity firm out of Birmingham, Michigan, to build out a home-based care platform really focused on the dual eligibles, right? Really focused on how do we do some of what I was talking about? How do we provide a more coordinated service delivery model for dual eligibles, and really leverage that home care aid and what and their capabilities and what they're doing in the home.
Yeah. Yeah, I know we chatted about 6 weeks ago, and I know you're passionate about how data needs to be shared in structured ways for patients that are dual eligible. Can you share with us from your past some of the limitations that you've seen in the industry, and how can we just improve and do better to empower the people that spend the most time with clients in their homes?
Yeah. I mean, so I think so a couple things. One of the things that I found, and I do see some changes in this regard, and I'm certainly not the first person to think of this. I think it's not hard to find a bunch of folks who are pushing for this, including the software vendors that support the industry. But it is, how do we, the caregivers in the home, and I'm talking on the Medicaid side, right? So people providing assistance with activities of daily living. As I mentioned, they know what's going on. They know intuitively, right? You have human beings there who can touch, smell, hear. They know what's going on. The question is, how do you create? And it is their job to report changes in condition, right? Part of the job description is, if you see a problem, pick up the phone and call the nurse, call the agency, and report it, so that action can be taken, the appropriate intervention can be made. But for the most part, we really weren't doing a very good job, if any job at all, doing that in any sort of structured, objective way, right? So the first task at hand was to say, how do we start to do this in a way that gathers objective information and captures it in a structured way so that we can do something about it. So we did get quite far, and with that in Simplora, and I'm sure that work continues today, where we've trained aides basically to go in and using and EVV in the home care space, right? So effectively lays down it lays down the plumbing to capture that information, right? So you already have aides going in and having to clock in and clock out anyway. We're going to take on the headache of educating them on the new process to go in, clock out using a device or telephonically. So it's not that hard to add additional data elements to that plumbing, so to speak. So we went in and we structured a process and trained the aides on reporting changes in condition based on a few key questions. Captured that data, brought it in house, had the nurses review it. A lot of data, maybe 1% of the time you're actually getting data that you need to take action on. But it's 1% across thousands of patients that you see every day adds up pretty fast, right? And you're solving real problems. So we did put that in place. I think the challenge that we've got, in my opinion, and I'm interested in your thoughts on this, and certainly your thoughts on this, Jennifer, is trying to get somebody to care, in my opinion, was really challenging. And care is not fair. Trying to efficiently coordinate with others on the care team is challenging, right? So if you think about it, we'd find out what, in the analog world, the aide sees a problem, they pick up the phone, they call the agency, they talk to the nurse, and the nurse then reaches out and discusses with the family what's going on. And then maybe what happens is the family then, and hopefully if we can get a hold of the primary care doc, we would do that as well. But more often than not, it's a discussion with the family to see what is the issue going on, and how do we, and what's the intervention we need. And then it's on, now we've handed it off, so to speak, to maybe it's a primary care physician who's got to start all over again, right? Now they've got to get an appointment, they got to get them out there, maybe they were talking about adjusting the medications, but it's not a seamless process at all. And that was a challenge. So, and I think just because we put in place technology to have the aides report those changes in condition in a structured way with objective data, I still have that same problem, right? You still wind up having that, that inability to engage the other team members to really take action. So I think that's there's so much you can do. And I think there's a tremendous opportunity to really coordinate with providers on the acute care side of the house that's paid for by Medicare in a way that I don't think that we, overall the delivery system is doing a very good job at today. And really sort of building that out is what I'm working with the Lorient team to do today.
Jennifer, your thoughts?
Yeah, I mean, all great points that Richard has there. I mean, I think, obviously I'm going to come at it from that technology side. How can we link all of those pieces together? And that's, a lot of the work that we're doing at Medalogix across that continuum is really looking at how do we make sure that the right data points are getting in front of the right people at the right time. And so what our products do is they'll go in and they'll extrapolate like those key things that Richard's kind of talking about. And then we're able to put that in front of the clinician to make some real-time decisions, or the IDG team to make it, the interdisciplinary team to make choices for those patients at the right time. And so leveraging that technology along the way is going to be huge. I think it also, the more we can leverage the technology, the more we can practice at the top of our license, and, let those clinicians be at the bedside at the right time with the right patients, and really having that holistic communication circle from whether it is the home health aide to the chaplain to a nurse to a social worker to PT, OT, ST. How do we link those guys all together so that we're making a holistic care plan that meets the needs of the patient, and then thus also is managing that patient across the continuum?
So if we take a step back, we can do a better job at making sure there's coordination and collecting all the data that we can across the Medicare-Medicaid divide. Let's take one step back. In your opinion, what does typical onboarding look like in home care and home health across the industry? And what can we do better, and how can we do better?
That's a great question. So obviously we're dealing with shortages across the nation, with clinicians and aides at this point. I mean, we're just seeing such a stretch. Most of our customers and clients are really, really struggling with that. And they're always looking for how do we better serve and retain our staff. And a lot of that is related to, are we getting them the right information? Are they trained correctly? Or do they know what their job means? Do they have the tools to do their job correctly? And that's where a lot of the technology, whether it's upgrading the telephony for the home health aides so that they can communicate more readily and they know how to use that. They can get the data in, whether it's the nurse at the point, with a point care device, or in the home, being able to quickly put in information or extrapolate information so that they can make real-time decisions with the patient at the right time. And that's where a lot of our products are headed. One of the things that's on the horizon for Medalogix is really looking at how can we predict patient, or not even so much patient, but how can we predict turnover on a staff person. And so just like leveraging the EMR that we do today for our predictive analytics to service a patient and a patient at the right time, we can also see when a clinician or staff person, now their behavior starts changing within the technology. And if they're not syncing, and they're always one that will seek their device right away at 8 a.m. They never miss visits. They're always great with documentation. Now we can use our predictive analytics to now see that we're starting to see a dip in productivity. We can catch it quicker. The agencies can catch it quicker rather than having a unhappy and unsatisfied employee and then them getting, going to the next job. We've seen a lot. I had to laugh the first time one of our clients on our consulting side said, "Yeah, we have over 100% turnover rate on the West Coast." And I was like, "What's 100? How do you get to over 100%?" And he goes, "Well, we hired, this nurse on January 1st. They left on June, and then they came back again in December." I mean, so it's like that, and you think about the cost to that recruitment at each time, it's a minimum of $35,000 a clinician. I mean, it's insane the amount of money that these agencies are having to put into it. So our goal at Medalogix is really to help build out a technology that will help agencies be able to see that quicker. It might be something personal in their life. It might be health related. It might be you hired a new branch director and that's not a good fit for the culture. And so being able to capture those things quicker and allowing the leadership to be able to see that is one. Two, though, along with just having the most up-to-date technology for these people to use so that they're not sitting behind a desk and documenting and pushing different, workarounds and things like that to just get their job done. Make it efficient for them. Investing in technology really is really where I think we got ahead, because people will go where they feel most supported, most heard, and have the tools to do their work.
Yeah, I think you make a great point. I think that's right. I think it's on the, how do you empower, how do you really make people feel like, and thinking about the AIDS, it's funny you talk about the negative, think like what happened? Did they start on June? They were starting June 1st, but they quit on May 29th, which, unfortunately does happen because you have so many people no showing for the jobs. But I think, seriously, to your point, I think one of the things we found was, and again, this is I'm talking about the home care aid, service line, but by beginning to engage them in the process, I think one of the biggest challenges in that space is the caregiver. There's not a lot of recognition for the value that the caregiver brings, right? And I think you and Jennifer, you and I talked about this, offline earlier. And the challenge with, and as a result, if you look at it, if you look at the experience of these caregivers, like it's a hard job. It does not pay a lot of money, and we're not going to solve what we pay them anytime soon, right? That's a tough nut to crack. But we can do a better job. Obviously culture is a huge part of it, and sort of respecting the work that they do. But we can also do better. But in so doing, make them part of, realize and appreciate the value that they bring to the care, to the delivery system. And at least from what I experienced, that doesn't really happen, right? I mean, I've been sort of testing this thesis, the thing we chatted about, trying to build a delivery system that does a better job coordinating care across the different platforms. And I think and certainly it happens, right? It is not without incidents that happens, but for the most part, but I think there's a lot of cases where people just don't really necessarily have a whole heck of a lot of respect for what that caregiver does bring to the table. They think, they clean the house, and I think, and as a result, they experience that, and what I've seen in the agencies is that a lot of the interaction between the clinical side and the aide is very one way, right? It was very much, when we would have supervisory visits, it was the nurse showed up and they would tell the aide what not to do, and they would talk to the client and they'd leave. And there wasn't much of a two-way conversation, sort of engaging the aide on what's going on in that house. When we put in place using technology, when we put in place sort of how do we begin to get that structured information, objective data out of the home, and with some training to the caregivers, all of a sudden the caregivers are bringing up information to the clinicians that's important. They say, hey, I did notice a change in condition. I noticed something's going on. And then then the nurse calls in, talks to them, and goes, well, what's going on? And they start having a conversation that is about the client, that's about the shared interest. And one of the things that we found in surveying these caregivers as part of the rollout of this program was an increase in their sense of empowerment, right? I mean, so they felt like they played a meaningful role in the overall care of their client. And that increased confidence in their job. It increased confidence in it increased their confidence of managing the care of their client. And one of the things I did learn before I got here in my prior days on the analytics side was like, well, that's a huge driver of good outcomes, right? If you can increase confidence in care, good things happen, right? Well, I will say we know bad things happen when people aren't confident in care. And I would suggest that applies not just to the individual and they're managing their illness, but if I've got a core caregiver who's not confident in what I'm doing, well, nothing good's going to come of that. So I think that, how do we, to your point, Jennifer, how do we begin to put in place the tools? Because to do any of this stuff at scale, right, we need the technology, because otherwise it's not going to happen. I mean, and so I think the technology, so leveraging the technology and the ability to begin to transact data for some of the purposes we're talking about allows us to actually scale this business. Because otherwise, it's all one-offs. And as you know, like finding and retaining staff is the most, that this whole industry, that's it. That's the key to success in this entire business is how do we get and retain staff? And if you feel good about what you do, you're likely to continue to do it. And if so many agencies that we just, you find any warm body, you say you want to do, I take you and I put you to work, and chances are I'm going to put you on the most difficult case that I can't staff because I just got to fill a gap right now. And that day's not sticking around. They're gone. I mean, they're not supported. So, and I think we really need to arm them with the technology that supports the communication and collaboration and coordination that I just don't think exists in any way near where it needs to.
Yeah, I know. To add to that, like one of the things that we focus really highly on the MHA side, our consulting side, when we are implementing a technology, it's showing the entire organization, everybody that's touching, whether they're a back office or a field staff, whether they're chaplain or a therapist or a home health aide or whatever that might be, that when we're leveraging that technology has a purpose and a mission, and you are a pivotal part of that technology and the use of that technology. So when we go in, we don't teach you how to turn it on and where to push the buttons. I mean, yeah, that's part of the process, but we teach them the why behind it. Why does your documentation mean so much? Why? And so now I have, no matter what level I'm at, I have value to I add value to the organization. I add value to the patient, and now I have something I feel proud of. And so, we throw them all together in a room, all levels, and we have that whole round discussion, and everybody hears that, you know what, if so-and-so doesn't get this done, then this doesn't get done, then this doesn't get done, then we have a patient failure. And so this is a team effort. And, I mean, even on our technology company, you work with culture because everybody's kind of you've got your dev team, you got your tech team, you got your product team, you got marketing, you got sales, got all operations, and everybody's working in their own little funnel. And there's days where people feel not satisfied from whatever reason. And I don't care if you're the janitor to the CEO of the company, you make a difference to that organization. And that's something that we at MHA preach all the time. I don't care what level you are important to this organization. You are important to those patient outcomes, and you add value. And that's just, again, that's a cultural piece that organizations are fast adopting because of the shortages and the turnovers in the space.
With the shortages, is there anything in the Internet of Things space that excites you guys? So as an example, if mom always comes downstairs by 8:00 and her fridge door opens by 8:30, is there anything that you guys have seen that you're pretty excited about?
Well, I know on our Metalogic side, we've talked with a lot of telehealth vendors, whether it's the Whoops, the Apples, the Garmins, all the other different devices. I think the discussions that we're having today, and where we're going to see a shift. So it's like, do we put a stopgap in it right now and find a technology that works for the senior population that we're working with today, that may not be as technology savvy, versus the new senior population that we will be seeing aging in place in the next 5 years that is highly tech savvy. So I think that there's some fun opportunity there, and we've had some really great dialogue with some potential strategic partners in that space to look at, is it just, is it something you wear 24/7? Is it something, a camera? Is it an iPad? Is it a this or that? I think there's a lot of opportunities out there, and we've talked with a lot of vendors we do a lot of vendor mentoring on our MHA side. So I work with a lot of other partners that are trying to come into the space and trying to fill the value prop. And so I think that value prop is continuously evolving, because we now have such morphed population and a lot of education that'll be in the home here very soon.
And Rich, I wanted to ask you on the personal care side. We didn't really dive too much into the innovation that you've seen. I'm presuming it does lag behind the home health side. What are some of the things that you've been excited over the past number of years on the innovation towards getting better with the things that we're talking about today?
I mean, a few things. I think on the, I think I have to imagine, with as good of a job as, companies like Match.com have done on figuring out how to take different personalities and make them work, we can do better on that front in the home care staffing arena, right? Like I've got to believe, and I don't remember who it was early on. We started having conversations with a few different folks who were working on some different models in this regard, but I've got to believe that we could do better there. I think. There are different solutions out there, and different people are bringing different ideas to the front. And I've seen some that are impressive that have sort of easier to use front ends, but staffing is going to get increasingly complicated. There just aren't enough people to do the job at hand, right? We just don't have. There's no staff. The issue is not there's more than enough business to go around. You just can't staff it. So the question is, how do we make the right match so that it sticks, right? So that you wind up having, so the client so there's a match there and it sticks. And how do I make it more efficient so that when you have when you have the human being behind it trying to manage the process, they can efficiently find the right aid to put on the right client at the right time? That's still really a cumbersome process. And I've got to believe we can do better in that regard. The other thing I'm also really passionate about, and again, I think this also is coming from, it's along the lines of what Jennifer's talking about on the AI side and predictive analytics side, and really where I came from in the work I was doing with 3M before I got to Metro. How do we do a better, these caregivers in the home, like we could probably get really smart on how to predict based on observations and questions, how to predict what's going on in that home to get in front of potentially bad outcomes, right? I mean, you don't have to have, from a predictability standpoint, I think getting to 94-97% is, that's very, that's fantastic and hard to do, extremely hard to do. But man, if you just got to get better than the flip of a coin. If I can even just be more predictive than not having no idea, we've demonstrated improvement from where we are today. And I just don't think that it would be that hard to build out predictive models where that caregiver can provide some. And if you so think about some of the Medicare Advantage benefits, right? So there's a lot going on right now where Medicare Advantage is funding personal care and personal care. I mean, benefits where you've got a caregiver take a client home post-hospital, particularly a high-risk client, right? Somebody who is, maybe they live alone, they've got cognitive issues, ambulation issues, maybe vision issues. A discharge planner at a hospital who certainly doesn't want them coming back into readmission could help you could help you screen folks on certain high-risk indicators. You flag who they are. You pay for a caregiver for 4 to 8 hours. That caregiver takes the person home, picks up the meds. You get to the house. This person if they live alone, they've probably been in the hospital for 2 weeks. Like, that house is not in good shape, right? There's probably a bunch of rotten stuff in the fridge that's got to get thrown out. The place has probably got to get cleaned. So you have someone go in, they do a laundry, they do some food shopping, they situate the person. But at the same time, I ask a few key questions, right? I can do a risk assessment that's within the scope of that aide's capabilities, right? So I don't have to go out of scope of practice, but I can do some basic observations, and I can risk stratify that person. And now what that person finds out, that then goes out to their care manager. It goes out to the care manager, whoever that may be, right? And so the nurse, so if a certified agency was going to be there, right, chances are they weren't going to be there for 24 to 48 hours. Well, a lot of really bad stuff can happen in 24 to 48 hours. So now you get an aide there, they risk stratifying. You got to get someone here like now. We need to get, this person is walking back into this situation. All those social determinants of health, like, you got to lay eyes on that. Care managers, they're all telephonic, managing 150 clients. Like, they don't. But you could easily put someone in that home. And now, can we figure out a benefit? Can we fit that into some of the benefits out there that are now being funded? So that's a really long answer to your question, but I think the ability for the paid for resource in the home. I realize I'm a bit of a hammer with a nail on this one, because this is sort of where I've been for 7 years now. But the care that's a smart person, intelligent person who can give us some pretty critical data, and I think we can do a lot with that.
Jennifer, give us a reason to be optimistic about the future of home care and home health.
Well, obviously it's going to be, it's not a small, a population that's getting smaller. It's going to be getting bigger. So we're going to be predictably bigger. We pretty much have those statistics in front of us. I think the other piece is really honing in on how do we recruit even upstream. Now, I know some of the more sophisticated programs are out there that have, whether it's an aide training that's mobile or remote, or even just the nursing programs that are coming out. What we've seen historically with most nursing programs, they don't get that exposure to community-based services. So whether you're going for your LPN, LVN, RN, BSN, whatever it is, that is not an exposure point. One of the things that we're doing at MHA is we're actually in discussion with a nursing school to really actually be a community-based track for them to teach them home health, hospice, and then link with some of our larger partner home health and hospice agencies to funnel them through their clinic process. And then we will certify them on their technology so that they are hand ready to go the day they graduate. And the agency can then choose to whether, they keep that clinician or that aide or whatever, or they pass on them, but they get the right of first refusal for them bringing them in. So really that's where we're headed from the MHA side, to get really kind of creative and help get them right out of the gate. Usually we see people, most of our clinicians to date, they started in the ER, or they started in OB, or they started in a clinic. And now they're like, I want to be something more. I want to be something more independent. You also get I don't even know what order we in, X-Geners. I don't know which generation we're in now. I'm getting old. But those young adults coming out, they are true entrepreneurs. They want to make a difference. You see the way they passion things in whether it's social media or their education. Home health and hospice is probably the most rewarding, most entrepreneurial, independent type of satisfying work that someone could do in the home. And we need to like boom that from every bell tower that we can, because if you think about it, whether it's an aide, whether it's a nurse or whatever, they get to, they have their schedule. They get to meet with their nanas and papas, and they get to have those intimate conversations and direct care at that time. They are the ones that get to ultimately make that immediate difference on that patient in the home. And so how can we, they can say, I want to see 10 patients a week or 50 patients a week or whatever it might be. But now they are kind of directing their career. They're also making an impact one by one, which is making a total impact to the industry, which to me, that's why I'm still here. I might not be at the bedside anymore, but the technology that my companies are doing and that my consulting teams are bringing to these agencies brings value. And that's what I love. And I get up every day and I'm excited about that. And I want to help bring these new generations along to help guide them through that process. And so between Medalogix, Muse, and then our Maxwell investment partners, we're really trying to bring that technology to the forefront to really engage that next level.
Yeah. And I love the idea of swimming upstream to change the education path. Google is doing this. So they have a 6-month program that is taught by their own engineers that's at a fraction of post-secondary education. And they recognize it as the equivalent of a 4-year university degree. And guess what? They have the right of first refusal on that talent as well.
Right. Yeah. I mean, it just makes sense. I know, typically in historically agencies are wanting 1 to 2 years of experience. Well, how can these clinicians or how can these nurses get 1 to 2 years experience to even step foot in a home health or a hospice agency? Yeah. How about we nurture them along the way and they're ready?
Yeah. And still, instead of waiting for serendipity to happen at some stage.
Yeah.
Yep.
Well, folks, I'm sure we could chat all day. I've learned a lot of things here today. We are bumping up against our time. So I'll get you out of here on the same question. Rich, I'll start with you. What's next for you? What can we expect? And if someone wants to follow you online, what would you suggest?
I mean, what's next, I think, as I mentioned, I'm working with the team at Lorient to build out this platform that, that I described, really, focusing on that dual eligible population and how do we put together a sort of a coordinated delivery system, sort of 3 legs to the stool, right? Medicaid funded home care, Medicare funded episodic nursing, and primary care, which is going to be primarily Medicare funded. And really put that together. That's the focus for the next few years, and see if we can get something out there that's really making a difference.
Jennifer, over to you.
Yeah, well, obviously there's never a dull moment in the Maxwell household or businesses. So definitely Medalogix, being strategic advisor there and really helping kind of grow, heading towards kind of a potential payer solution. We've got a palliative care product that we'll be working on in 2022. We also have the retention one that I mentioned. I'm also an investor, sit on the Element 5 board, which is robotic process automation. So we're trying to engage kind of those tools to help kind of transition that as well. Along with our other investments that we work with, we're keeping our ear to the ground, helping pivot and be flexible as the needs of the industry change. And Maxwell's going to continue to grow, and we're going to continue to be able to look at how do we leverage those 3 prongs: people, process, and technology for the future of healthcare.
Well, that's super. Thank you both for coming on again. I know you guys are working on some big ideas that I'm going to be following very closely. And hopefully soon enough, we'll be able to meet up in real life someday soon.
Sounds great.
Yeah. Thank you.
Take care, guys.
It's been great. Take care.
You.
Bye.
Bye.
Home Health 360 is presented by AlayaCare. First off, I want to thank our amazing guests and listeners. To get more episodes, you can go to alayacare.com/Home Health 360. That's spelled Home Health 360. Or search Home Health 360 on any of your favorite podcasting platforms. The easiest way to stay up to date on our new shows is to subscribe on Apple Podcasts, Spotify, or wherever you get your podcasts. We also have a newsletter you can sign up for on alayacare.com/Home Health 360 to get alerts for new shows and more valuable content from AlayaCare right into your inbox. Thanks for listening, and we'll see you next time.